Have you ever found yourself sitting in a clinic waiting room, scrolling through your phone and just wondering why it takes so long to see the doctor?
Oh, absolutely. It's a near universal experience, isn't it?
Or maybe you're on the other side, you're a healthcare provider, and you're just buried under this mountain of admin tasks, feeling that burnout, wishing you could spend more time, actually caring for patients.
That pressure is immense. We hear about it constantly.
And then there's just the sheer volume of information doctors and nurses have to juggle every single day, trying to keep track of every patient, their history, the latest guidelines. It's overwhelming.
It truly is. It's a huge cognitive load.
It's this challenge that really touches everyone involved in healthcare, right? Kind of persistent bottleneck in a system that's supposed to be about healing.
Exactly. A bottleneck is a good way to put it.
Well, what if I told you there's a powerful and actually quite tangible solution emerging right now, one that promises to tackle these exact pain points head on?
Okay, I'm listening. What have you got?
Today, we're taking a deep dive into the targeted application of artificial intelligence in healthcare. And look, this isn't just, futuristic concepts or buzzwords floating around.
Right, we're talking practical applications.
Exactly. Practical, impactful AI that is fundamentally transforming what's known as ambulatory care. That's your local clinics, your outpatient centers, your doctor's offices.
The places most people interact with healthcare most often.
Precisely. Our deep dive today is inspired by a really comprehensive analysis. It's titled The Augmented Clinic, AI-powered patient flow, labeling, and workflow facilitation in ambulatory care.
Sounds like a meaty source.
It is. And our mission today, as always, is to unpack the highest value opportunities AI presents right here in this sector. We want to understand the absolutely critical role of human-centered integration.
That human piece is key.
Totally key. And explore how AI is actually reshaping the very roles within the care team. So this isn't merely about rolling out new tech.
No, it's much bigger than that.
It's about a fundamental clinical transformation, one that promises to make healthcare more efficient, maybe more human, and ultimately just more effective for you, the patient. Let's get started.
Yeah, let's do it. It's compelling how the analysis jumps right in, spotlighting these precise areas where AI can generate the most significant, measurable value in these ambulatory settings.
Okay.
It meticulously categorizes the potential into three crucial domains. First, optimizing that journey patients take through a clinic, the flow.
Right, the flow.
Second, intelligently categorizing patients, they call it labeling, for more proactive care.
Labeling.
Interesting term. And third, streamlining the day-to-day administrative burdens that, well, they often just overwhelm clinical staff.
Paperwork pile.
Exactly. But the foundational insight here, the real takeaway that underpins everything, it's that the greatest value emerges not just from the AI tech itself, powerful as it is, but from its seamless, almost invisible integration into the existing clinical workflows, how people actually work day to day.
So it has to fit in naturally.
Perfectly. And critically, it demands a robust, human-centered change management strategy. Without that vital people piece, even the most sophisticated algorithms, no matter how clever, well, they'll struggle to make a truly meaningful impact.
That makes perfect sense. It's not just about the code, is it? It's about how people engage with it, how it serves their needs.
Precisely. The human touch remains paramount.
So let's really dig into that first pillar you mentioned, patient flow optimization. From what I gather, this is truly the operational heartbeat of any clinic, isn't it?
It truly is. Think of the patient schedule as the pulsating core of a clinic's daily operations. The source material vividly illustrates how any inefficiency here. It just causes this cascading ripple effect.
Ripple effect, how so?
Well, you get frustrated patients facing longer waits, you have overworked staff scrambling to manage what feels like chaos, and significantly lost revenue because appointment slots go unfilled or bottlenecks prevent new patients from even getting in.
Right. And historically, managing this has been, what, just reactive, putting out fires?
Exactly. You wait for problems to crop up, then you try to fix them. AI, however, it fundamentally shifts this whole paradigm. It moves towards a truly predictive model.
Predictive, okay.
Allowing clinics to proactively optimize the entire patient journey, right from the moment they book that appointment all the way through to when they leave.
So we're talking about intelligent scheduling, much better throughput management. My first thought immediately goes to patient no-shows. That must be an absolute massive drain, a huge frustration.
It's an immense, persistent challenge. And the numbers are quite startling, actually.
How startling.
Some practices incredibly report no-show rates as high as 80%.
80%. That's unbelievable.
Imagine the operational and financial impact of that. The analysis translates this directly into real-world costs. It estimates that each daily no-show slot costs a practice around $26,000 per year in lost revenue.
Wow, $26,000 per slot per year.
It's not just wasted clinical time. It's a direct hit to the bottom line. It hinders a clinic's ability to invest in better care, better equipment, and it's a huge barrier for other patients who desperately need those slots.
That's a staggering amount of lost potential. So, how does artificial intelligence actually tackle something as seemingly unpredictable as, predicting whether someone will show up? Almost sounds like a crystal ball.
Yeah, yeah, it can seem like that. But it's less like magic and more like incredibly sophisticated pattern recognition. Predictive analytics.
Okay.
Machine learning, or ML models, can predict the likelihood of a patient missing their appointment with remarkably high accuracy. Often, they achieve AUC values.
AUC, remind us what that means again.
Right, so think of AUC, area under the curve, as a kind of comprehensive report card. It shows how well an AI model can distinguish between two groups. In this case, those who will show up versus those who won't.
Okay, so higher is better.
Exactly. A score of 1.0 is perfect, and anything above 0.90 is considered excellent. These no-show prediction models, they frequently exceed 0.95.
0.95, that's near perfect discrimination. How do they do it? What data are they looking at?
They analyze a really rich array of data points. Everything from the appointment lead time, meaning how far in advance it was booked,
Okay, that makes.
the patient's prior no-show history, which is a surprisingly powerful indicator,
I bet.
patient demographics like age or location, maybe distance to the clinic, and even the specific type of reminder sent. Was it an SMS, an email, a phone call? The model learns which combinations are most predictive.
And once you have that incredibly precise prediction, what are the practical interventions? How do clinics actually use that information on the ground to make a difference?
Great question. There are two primary high-impact interventions enabled by this predictive power. First, targeted reminders.
Oh, targeted.
Yeah. So instead of just blasting generic reminders to every single patient, clinic staff can focus their valuable outreach efforts, their phone calls, their personalized messages, specifically on those patients the AI flags as high risk for no-showing.
Making their follow-up much more efficient.
Incredibly efficient and impactful. They engage directly with those who need that nudge the most. Second, and this is where it gets really strategic, is intelligent strategic overbooking.
Overbooking. Doesn't that just lead to longer waits if everyone does show up?
That's the traditional fear, right?
Yeah.
But this isn't random overbooking. The system, using these accurate predictions, intelligently double books only those specific slots that have a very high probability of becoming vacant anyway.
Oh, okay. Data-driven overbooking.
Exactly. It's designed to minimize wasted clinical time and maximize the number of patients seen without significantly increasing wait times for others. And the impact is profoundly tangible.
How tangible?
One AI-powered system managed to reduce no-shows so effectively. Get this. It allowed an additional 80,000 to 100,000 patients to be seen annually at a single NHS trust.
80 to 100,000 more patients seen, just from tackling no-shows.
Yep. That represents an enormous boost in patient access and overall clinic efficiency. It's huge.
Wow, that's an absolutely incredible leap in access. So it's not just about predicting who won't show up, but also about proactively creating more efficient schedules from the very beginning. I imagine this applies to something as complex as surgical scheduling, too.
Absolutely, you're spot on. Beyond just mitigating no-shows, AI's true power extends to proactively building far more efficient schedules right from the start.
Like for surgeries.
Exactly. Take surgical scheduling, which is notoriously complex. AI models can analyze vast historical data on actual procedure durations, not just the booked time, but how long things really took.
Learning from reality.
Precisely. Taking into account granular details like surgeon-specific patterns, some are faster, some are more methodical, the type of surgery, and critically real-time resource availability.
Resources like?
Things like the number of available operating rooms, specialized equipment needed, recovery beds, even staffing levels for that specific day or procedure type. It's dynamic.
Got it.
The key goals here are crystal clear and highly impactful. drastically minimize patient wait times, reduce that expensive staff over time.
Which helps with burnout, too, I imagine.
Hugely important for reducing burnout, yes,
Ah.
and maximizing the utilization of those incredibly expensive assets, like operating rooms or specialized exam rooms, making sure they're not sitting empty.
And are there compelling real-world examples of this actually working? Because it sounds like it could have a truly transformative impact on a hospital's bottom line and, patient care.
There are some truly powerful success stories emerging, really compelling stuff.
Like what?
For example, an ambulatory surgery center. So, outpatient surgeries, they embraced machine learning for their scheduling. They saw a remarkable 21% reduction in overtime rates.
21%. While keeping volume the same.
Exactly, while maintaining their surgical volume. And this translated into an estimated savings of $469,000 over just 3 years.
Wow. Nearly $500,000 saved.
Another great illustration comes from the Providence Health System. They use an AI tool to reduce unused operating room block time, those reserved chunks of time that often go empty by a significant 34%.
34% less wasted or our time.
Right. And this wasn't just about saving money. It directly created more capacity for surgical cases without having to build any expensive new operating rooms, just making existing resources work harder and smarter.
That's efficiency to find. Any others?
Yeah, perhaps most strikingly, a hospital in Kansas City. They implemented AI for automated scheduling. They were able to perform 7% more surgical cases,
7% more.
despite at times having to close 20% of its operating rooms due to other operational constraints, like staffing or maintenance.
So, more surgeries with fewer rooms available. That's incredible.
It really shows the power of optimization. These are not minor incremental improvements. These are transformational shifts in operational efficiency and patient access.
Mm.
The core insight here, I think, is that AI isn't just making things faster.
It's making them.
It's making complex, interconnected systems predictable and adaptive, which ultimately kind of restores dignity to the patient experience by reducing those frustrating, anxiety-inducing delays.
Those numbers are absolutely staggering, demonstrating really profound impact. But it's not just about the upfront scheduling, is it? It's also about managing the patient flow in real time, like as the day actually unfolds within the clinic.
Precisely. That's another crucial layer. AI tools also provide this dynamic, panoramic, real-time view of clinic operations.
Like an air traffic control tower for the clinic.
That's a great analogy. Yeah, this capability is absolutely crucial for preventing bottlenecks on the fly and vastly improving the patient experience throughout their actual visit.
How does it track them?
AI-driven platforms can continuously track a patient's journey through various stages: registration, triage, waiting for the exam room, treatment, checkout, discharge. They leverage the rich, granular data that's already in the electronic health record, the EHR.
The digital chart.
Right. The digital hub of all patient info. These systems create intuitive, real-time dashboards. They monitor wait times, patient locations, room status, overall flow.
And this empowers who? The clinic manager.
Clinic coordinators, managers, even charge nurses. It empowers them to proactively manage potentially high-risk appointments, maybe one running way over time, or to dynamically reallocate patients to a different clinician or an open exam room to cut down immediate wait times,
Yeah.
and to optimize resource use instantaneously based on life conditions.
So it's giving them that aerial view to make quick, informed decisions rather than just, reacting blindly when things get backed up.
Exactly that, and the results can be truly dramatic. Some hospitals have reported a remarkable 71% reduction in patient wait times using these real-time AI-powered systems.
71% reduction. That's huge for patient satisfaction.
Huge. And this real-time coordination isn't just about a dashboard, though. It also involves seamless, automated notifications. For example, the system can instantly notify pre-op staff as soon as a patient leaves registration, while simultaneously alerting the surgical team, patient X is on their way, prep for procedure Y.
Smoothing out those handoffs.
Dramatically reduces delays between stages of care, and it enhances the overall patient experience by keeping everyone informed and aligned throughout the patient's entire journey. The insight here is that efficiency isn't just a cost saver.
It's also...
It's a direct pathway to enhance patient trust and reduce anxiety. It transforms the very feeling of being a patient, and honestly, the feeling of working in that clinic too.
That's incredible. So from predicting no-shows, optimizing complex surgical schedules, to managing real-time flow, AI is making operations much smoother, more efficient, and definitely more patient-friendly.
That's the goal, absolutely.
Now, let's shift our focus a bit to the second core pillar you outlined: intelligent patient labeling. What exactly does that mean? It sounds a bit clinical. Why is it such an important development?
Yeah, labeling might sound a bit impersonal, but it essentially refers to the sophisticated use of data and AI to categorize, or maybe better put, stratify patients into specific groups.
Stratify.
Well,
Yeah. Okay. For what purpose?
for proactive, highly targeted, and ultimately more efficient care. It's about moving beyond just a simple diagnosis like diabetes to identify individuals within that group who might need particular interventions, closer monitoring, or maybe a different, more personalized care pathway altogether.
So it's adding nuance.
Exactly.
Hmm.
It fundamentally shifts healthcare from that largely reactive model where you treat problems once they appear to a proactive one, where you anticipate needs and intervene early before things escalate.
Okay, so it's about identifying specific patient groups that might need something extra or different before a crisis hits. And you mentioned one of the most mature applications here is risk stratification. That seems incredibly valuable.
Yes, risk stratification is indeed one of the most mature and widely adopted applications of predictive analytics in healthcare today. It's been around in various forms for a while, but AI makes it much more powerful.
How widespread is it?
A comprehensive 2023 survey revealed that a remarkable 79% of hospitals are already utilizing algorithms in some way to identify high-risk outpatients for targeted follow-up care.
79%. So this is already happening at scale.
It is. These powerful tools analyze vast amounts of diverse patient data, way more than a human could realistically process for every patient to intelligently flag individuals who require closer monitoring or specific preventative interventions well before their condition might escalate.
And this includes identifying high-risk patients for chronic disease management. That sounds incredibly valuable given how common conditions like diabetes or heart failure are.
It truly is indispensable for managing chronic disease effectively. These conditions, like diabetes, aren't just prevalent, they are major drivers of healthcare costs and, more importantly, morbidity worldwide.
So how does AI help there specifically?
Machine learning models can analyze enormous amounts of electronic health record, or EHR, data. And again, this isn't just a few data points. It's a comprehensive look at everything. Demographics, detailed lab values over time, a patient's full list of comorbidities, their current medications, even lifestyle factors if they're captured.
A really holistic view.
Right. The AI uses this rich data set to predict which patients are at the highest risk of developing complications from their chronic conditions. For instance, a model can accurately identify diabetic patients who are most likely to have poor glycemic control down the line, or who are at high risk of developing serious issues like nephropathy, kidney damage.
And knowing that risk allows.
It allows care managers to intervene proactively with highly personalized education, maybe more frequent check-ins, tailored follow-up appointments, specific dietary advice, whatever is most appropriate for that individual's risk profile. This proactive, individualized approach is absolutely fundamental to effective population health management.
Getting the right care to the right patient at the right time.
Precisely. Preventing those costly and debilitating complications before they happen.
And what about predicting hospital readmissions? That's another huge challenge for healthcare systems, right? Both in terms of patient well-being and those significant financial penalties hospitals face.
You're absolutely right. Unplanned hospital readmissions are a major headache. They're not only a significant financial penalty for healthcare systems, often tied directly to reimbursement models, but they also represent a breakdown in care continuity. It's a negative outcome for the patient, suggesting something went wrong after discharge.
So can AI predict who's likely to bounce back?
Yes, machine learning models have proven to be highly effective at predicting the 30-day readmission risk for patients discharged from both inpatient hospital stays and even ambulatory surgery settings.
What factors do they look at? What are the key predictors?
Key predictors that these models commonly identify include things like the number of prior inpatient hospitalizations or emergency department visits. Past behavior is often predictive. Also, the total number of comorbidities a patient has and their discharge disposition.
Discharge disposition, meaning?
Meaning where they're going after leaving the hospital. Are they going home alone, home with family support, to a skilled nursing facility, to rehab? That destination significantly impacts their risk.
Makes sense.
So by accurately identifying a high-risk patient at that critical point of discharge, the system can immediately trigger automated workflows.
Like what kind of workflows?
Things like automatically scheduling a crucial follow-up telehealth visit within a few days, or coordinating a home health nurse check-in, or ensuring medication reconciliation happens promptly. These targeted interventions are designed to proactively mitigate that readmission risk by ensuring continuous coordinated care during that vulnerable transition period.
That's brilliant. So it's about being proactive and precise, right at the most vulnerable moment for a patient leaving the hospital or clinic. Now let's talk about AI-assisted triage, specifically for same-day appointments. How does that work, and how does it truly streamline things at the front door?
Yeah, this creates immense efficiency and safety right at the point of entry into the care system. AI can effectively label or, again, stratify patients right when they first reach out, ensuring they get directed to the appropriate level of care quickly and efficiently, bypassing unnecessary delays. This is particularly valuable in busy primary care settings or even urgent care.
How does it assess them? Is it like a chatbot?
Often, yes.
Mm.
For same-day appointment requests, AI-enabled triage tools assess patient-submitted symptoms and medical history, frequently gathered through a user-friendly chatbot interface or maybe a structured web form. The AI then analyzes this information using clinical algorithms to assign an urgency score like how quickly does this person need to be seen and by whom.
And how accurate is it? Can we trust it compared to, say, a nurse or a doctor making that call?
That's the critical question, of course.
Yeah.
A rigorous study of one such AI triage tool for same-day appointments revealed a very strong correlation with general practitioner or GP assessments. It showed an impressive 84% agreement on the urgency levels assigned.
84% agreement. That's pretty high.
It is. And crucially, the AI was designed with a strong safety-first approach. It consistently tended to over-triage rather than under-triage.
Meaning it erred on the side of caution.
Exactly. If it was unsure, it would recommend a higher level of urgency. There were no cases in that study that the AI initially deemed non-urgent. They were later reclassified as emergencies by the GPs. That really underscores its reliability and safety profile.
So it's not just safe, but it makes things incredibly efficient for the GPs and the whole clinical team. What are the tangible benefits there beyond just safety?
The benefits are substantial. This intelligent approach significantly reduces the administrative burden on GPs, freeing them up to focus their expertise on the patients who truly require their complex judgment and care.
Makes sense.
It also ensures patients are directed to the most appropriate team member. Maybe it's a nurse for something straightforward, a pharmacist for a medication question, or a physician for a complex issue and in the most appropriate time frame.
And the impact on workload.
One system they studied notably reduced phone calls to the clinic by a remarkable 69%, and it decreased overall staff tasks by 20%. This led to reported operational savings of £300,000 for a primary care network in the UK.
Wow. Reduced calls by almost 70% and saved hundreds of thousands. That demonstrates immense practical value.
Absolutely. It's not just accurate, it significantly alleviates that administrative overhead.
That's a huge operational win, freeing up staff time for higher value activities. And what about AI-assisted triage in diagnostics? Especially in areas where there are specialist shortages, like dermatology. Can AI help a primary care doc make better decisions there?
That's another powerful and really practical application. In specialties facing significant shortages, dermatology is the classic example, but also things like radiology or certain surgical subspecialties. AI can serve as an invaluable triage tool for primary care providers, the PCPs.
How would that work?
Well, imagine a PCP encounters a suspicious skin lesion, maybe a mole that looks a bit unusual. They aren't dermatologists, so they might be unsure of the next best step. They could use an AI tool, maybe integrated to their EHR or via a smartphone app that analyzes an image of the lesion.
And the AI gives them?
It gives them an assessment, maybe a risk score, or suggests possible diagnoses. Studies have clearly shown that these AI tools can increase the diagnostic agreement between PCPs and specialists, like dermatologists, by 10–12%.
So it helps the PCP get closer to the specialist's assessment?
Exactly. It helps a PCP effectively label the case with more confidence. Is this something that genuinely requires an urgent referral to the dermatologist? Or is it something that can be safely monitored by the PCP in the clinic? Or maybe it's benign and the patient just needs reassurance.
Reducing unnecessary specialist visits.
Precisely. Which also often means reducing unnecessary invasive procedures like biopsies. It saves valuable time and resources for both the patient who avoids anxiety and extra appointments and the healthcare system by making sure specialist time is used for the cases that truly need it.
So the AI acts like an intelligent co-pilot, boosting diagnostic confidence for the generalist.
That's a perfect way to put it.
Yeah.
Enhancing confidence, ensuring proactive, targeted care without unnecessary delays or resource strain.
Fantastic. Okay, this brings us naturally to the third core pillar, Workflow facilitation. This sounds like it addresses a truly massive pain point for clinicians everywhere, the sheer burden of administrative tasks.
It absolutely does. And it's perhaps where AI offers some of the most immediate and, frankly, profound relief. The analysis strongly suggests that the most significant impact of AI in ambulatory care might actually be its inherent ability to streamline clinical workflows and dramatically reduce that administrative burden.
The stuff that leads to burnout.
Exactly. The stuff that has become a primary driver of clinician burnout. We're talking about those essential, yet often soul-crushing tasks that take doctors and nurses away from direct patient care, that drain their energy, extend their workdays into the evenings, and contribute significantly to feelings of exhaustion and cynicism.
And for any of this workflow stuff to truly work, it seems like the electronic health record, the EHR has to be absolutely central, right? Like it's the indispensable hub everything has to connect to seamlessly.
Precisely. This point cannot be overstated, and the source hammers it home. For any machine learning model to be genuinely effective and crucially widely adopted by clinicians, it absolutely cannot exist as a separate siloed application. You can't ask doctors to log into yet another system.
They'd never do it. Too much friction.
Exactly. Seamless, deeply embedded integration with the existing electronic health record is an absolute prerequisite, non-negotiable. The AI's output, whether it's that predictive risk score we talked about, a specific triage recommendation, or maybe a generated clinical note, it needs to be presented to the end user directly within the familiar context of the patient's chart.
Inside their normal workflow.
Right. This approach minimizes disruption to their existing way of working, dramatically reduces their cognitive load, they don't have to switch gears mentally, and ensures that they can easily and instinctively incorporate those AI-driven insights into their clinical decision-making without breaking their focus on the patient or the task at hand.
So it's got to feel natural, like an extension of their existing tools, not like bolting on another piece of software they have to learn and manage.
Couldn't have said it better myself. That's the key to adoption.
And you mentioned automated clinical documentation. This is where those really stark burnout numbers come in, isn't it? Physicians spending nearly half their day just on documentation.
That's precisely right. The sheer administrative burden of clinical documentation is frequently cited, study after study, as the primary driver of physician burnout. Some studies chillingly suggest physicians spend nearly half their workday on these documentation tasks.
Half their day not seeing patients but typing.
Exactly. It's an enormous time sink. It directly pulls them away from meaningful patient interaction, and it often extends their workday far beyond typical clinical hours, creeping into their evenings and weekends, impacting their personal lives, their well-being. It's a huge problem.
So how does AI help here? You mentioned NLP.
Yes, natural language processing, or NLP, that powerful subfield of AI focused on understanding and processing human language, offers a truly transformative solution here.
And this is where the concept of ambient AI scribes comes in, isn't it? I've heard about this. It sounds almost like science fiction, but how does it actually work in a real clinic?
It truly is remarkable to witness in action, and it's becoming much more real now. This emerging technology typically leverages sophisticated microphones placed unobtrusively in the exam room.
Microphones. Recording the whole conversation.
Yes, securely capturing the natural, free-flowing spoken conversation between the patient and the clinician during the visit. Then, an advanced natural language processing engine processes this audio.
Okay.
It automatically transcribes the conversation, and here's the critical part.
Yeah.
It transforms that unstructured spoken language, the doctor's questions, the patient's description of symptoms, the discussion about the treatment plan, the shared decisions into a structured, comprehensive clinical note.
Wow, it writes the note automatically.
Largely, yes. This note is then made ready, often within minutes, for the clinician's quick review and final signature directly within the EHR system they already use.
And the benefit for the doctor.
The profound beauty of this system is that it completely frees the clinician from the keyboard during the patient encounter. They can maintain uninterrupted eye contact, they can truly listen actively, they can focus entirely on the patient in front of them, fostering a much deeper, more present, and more human connection during the visit.
That's a huge shift. I can only imagine how much that would improve the patient experience, just feeling truly heard. But what about the quantifiable relief for the clinicians themselves? What's the real impact on their day, their workload?
The impact is significant and highly quantifiable. It offers substantial, measurable relief. Case studies and pilot programs have robustly demonstrated that this technology can reduce documentation time, the time spent actually writing or dictating notes, by a remarkable 50% to 70%.
50 to 70% less time charting.
Yes. And perhaps even more importantly, it leads to a significant decrease in reported feelings of burnout among physicians using it.
That's huge for retention and well-being.
Absolutely. The workflow integration truly transforms the documentation process. Instead of constantly splitting their attention between the patient and typing on a computer, clinicians can engage in a natural, unhurried conversation. After the visit, the AI-generated note is already largely complete, usually requiring only minor edits, clarifications, or additions, and then a final review before being signed off.
So it eliminates that after-hours work.
It drastically reduces that dreaded after-hours pajama time, as many call it, that's often spent catching up on charting. It gives clinicians back their personal lives and significantly improves their work-life balance. It's a genuine game changer.
That truly sounds revolutionary for clinician well-being and satisfaction. And it doesn't stop there, does it? You mentioned the detailed clinical information captured by NLP can then flow into other areas like automated coding and managing the revenue cycle, creating even more efficiency downstream.
Exactly. It's a seamless integration that unlocks further efficiencies. The rich, detailed, and importantly structured clinical information that the ambient scribe or other NLP tools generate can be intelligently leveraged to automate crucial downstream revenue cycle management, or RCM tasks. This further facilitates the clinic's overall workflow and, frankly, its financial health.
And this is where automated code suggestion comes in.
Precisely. AI systems are able to analyze that comprehensive clinical note, the diagnoses mentioned, the procedures performed, the complexity discussed to identify and suggest the correct billing codes.
The billing codes, like ICD-10.
Exactly. Those include ICD-10 codes, which specify what condition the patient has, CPT codes, which describe what procedure or service was performed, and also evaluation and management, or E&M codes, which indicate the complexity and time spent during the visit. Getting these codes precisely correct is absolutely critical.
Why so critical?
For accurate billing, obviously,
Yeah.
but also for compliance, and ultimately for the financial viability of the clinic. Inaccurate coding leads to denied claims, audits, and lost revenue.
So it's about making sure the clinic gets paid accurately and efficiently for the care provided without all that tedious manual effort by coders or clinicians.
Exactly, and minimizing errors. This significantly improves coding accuracy, which, as you said, is vital for revenue, but it's also increasingly important for risk adjustment calculations and value-based care reimbursement models, where accurate documentation of patient complexity directly impacts how much the clinic gets paid.
And what kind of accuracy are we seeing with AI-powered coding in practice? Is it reliable?
It's becoming remarkably reliable. AI-powered coding platforms, often using sophisticated deep learning models, are reporting impressive accuracy rates, frequently ranging from 95% to over 98%.
95 to 98% plus. That's very high.
It is. And by automating much of this code assignment, AI delivers multiple benefits for the revenue cycle. It dramatically reduces claim denials in some cases by up to 70%, which is a huge financial gain.
70% fewer denials.
It accelerates the entire billing cycle, ensuring faster payments, and it minimizes the need for those costly, time-consuming manual chart reviews and reconciliation processes by human coders, which are often prone to inconsistency and human error anyway.
So it's faster, cheaper, and more accurate.
Pretty much. This comprehensive integration from the clinical documentation captured naturally during the visit, straight through to automated accurate billing, all driven by AI within a single workflow. It represents a major operational step forward. It's a huge leap in achieving overall efficiency and financial health for ambulatory care settings.
The profound insight here seems to be that AI isn't just automating tasks.
Right, it's actually rehumanizing the clinical encounter by freeing clinicians from the keyboard.
And optimizing the business of care by ensuring accurate, timely reimbursement.
Beautifully put. That's exactly it.
Okay, let's unpack this a bit more then. This all sounds genuinely transformative. We've heard some incredibly impressive statistics: reduced wait times, way fewer no-shows, documentation time slashed significantly. But the crucial question, I think, for our listeners is, how do we know this actually works, like really works reliably? What's the real empirical evidence behind these compelling claims, and how do we precisely measure the performance of these sophisticated AI models?
It's a vital question, absolutely. And what's fascinating here is precisely how we measure the success of these AI applications in a robust, quantifiable way. You can't just rely on anecdotes. Strategic investment in machine learning, particularly in healthcare, absolutely requires a solid foundation of empirical evidence, not just hopeful projections.
So how do we measure it? What are the key metrics?
When we talk about model performance, we're generally looking at several core metrics, and we try to make them accessible, even if you're not a data scientist.
Good. Let's hear them.
First, there's accuracy. That's probably the most intuitive one. Simply the percentage of total predictions the model got correct.
Yeah.
Pretty straightforward.
Okay. Accuracy.
Then we have sensitivity, which is often also called recall. This measures how good the model is at correctly identifying the positive cases. For example, correctly flagging a patient who will actually be a no-show, finding the thing you're looking for.
Got it. Finding the no-shows.
Conversely, specificity measures the model's ability to correctly identify the negative cases. So in the no-show example, correctly flagging someone who will attend their appointment, ignoring the ones who aren't the target.
Sensitivity finds the yeses. Specificity finds the nos.
You got it. And finally, perhaps the most comprehensive single measure, there's the area under the receiver operating characteristic curve, or AUC.
AUC again. Okay. Break that down simply for us.
Right. Think of AUC like a comprehensive report card for how smart the AI is at telling the difference between two groups, say, high-risk versus low-risk patients, or no-show versus show across all possible decision thresholds. A perfect score is 1.0, while zero point 0.5 basically represents random guessing, like flipping a coin.
So closer to 1.0 is much better.
Much better. Generally, an AUC above 0.80 is considered good performance, and anything above 0.90 is truly excellent. It means the AI is remarkably adept at distinguishing between those two groups.
Got it. Accuracy, sensitivity, specificity, and the overall AUC score. So these are the critical technical benchmarks that tell us how reliable and effective an AI model is. Can you give us some specific examples now of how these models actually perform in the real world using these metrics, maybe starting with those patient flow applications?
Certainly. Let's look back at predicting patient no-shows. Studies consistently show very high accuracy rates, often ranging from 95% up to an astonishing 99.4% in some cases.
99% accuracy.
And the AUC values for these models are consistently excellent. Advanced machine learning approaches like bagging achieved 0.990 in one study, random forest hit 0.987 in another.
Just shy of perfect. What models are they using?
They use a mix of techniques: decision trees, logistic regression, boosting algorithms like XGBoost, and random forest. Think of these as different schools of AI, each with its own way of learning patterns from the data. They're effectively leveraging features like patient demographics, their past appointment history, the type of clinic, even the format of the SMS reminder sent. It really demonstrates their robust predictive power.
Okay, that's impressive for no-shows. What about optimizing something as incredibly complex as surgical scheduling? How do AI models perform there, where there are just so many variables constantly in play?
Right, it's definitely more complex. For optimizing surgical scheduling, models like XGBoost, especially when combined with techniques like SMTE for handling imbalanced data, where maybe long surgeries are rare, have shown an AUC of around 0.712 in some studies.
Okay, 0.712. That seems a bit lower than the no-show predictions. Is that still good enough?
It's a fair question. While it might seem lower numerically, for such a complex optimization problem with so many moving parts, an AUC of 0.712 is actually quite effective. And the direct, tangible outcome tells the real story here. Remember that ambulatory surgery center?
The one that cut overtime by 21%.
Exactly. That result came from a model performing in this range. It translated to estimated savings of $469,000 over 3 years. So it highlights that even an AUC in the 0.7s can still lead to truly substantial operational and financial benefits in a high-stakes environment like surgery. It's definitely making a difference.
That's a very compelling argument for its practical value, looking beyond just the AUC number. Okay, moving on to intelligent patient labeling. How effective is that AI-assisted triage for same-day appointments? You mentioned that impressive 84% agreement with GPs earlier.
Yes. For AI-assisted triage for same-day appointments, studies report that 83.7% categorical agreement with GP assessments. They also often report a kappa statistic, which measures agreement beyond chance of around 0.69, which indicates substantial agreement. It's reliable.
And the operational outcomes.
The real-world operational outcomes there are particularly striking, as we touched on. That 69% reduction in phone calls, the 20% reduction in staff tasks, leading to £300,000 in savings for that primary care network. It clearly demonstrates not just accuracy in the triage decision itself, but immense practical value in significantly reducing administrative burden and freeing up valuable staff time.
What about predicting hospital readmissions? We know that's such a critical and costly issue for healthcare systems. How well do the models perform there?
Predicting hospital readmissions is another area where AI really excels, offering that vital proactive capability. Machine learning models using various techniques like classification and regression trees, aggressive logistic regression, random forest XGBoost, even artificial neural networks collectively show a median AUC of around 0.81.
0.81. That's pretty good.
Yes, very good for predicting things like complications after surgery or 30-day or 90-day readmission risk. Random forest often performs particularly well in this domain, likely due to its ability to handle complex interactions within the data.
And the key predictors are consistent.
They tend to be, yes. Things like the patient's prior visits to the emergency department or previous inpatient stays, and the total number of comorbidities they have consistently pop up as strong predictors. These data-driven insights are invaluable for enabling those proactive interventions we talked about, which is crucial for both patient safety and avoiding those financial penalties.
And identifying high-risk diabetics. How accurate are the models in that critical area of chronic disease management? Can they really pick out the individuals who need more attention?
Yes, for identifying high-risk diabetics, the accuracy is exceptionally high, providing crucial support for population health management programs. Models like K-nearest neighbors, or KNN.
KNN, how does that work, roughly?
Think of KNN as looking for patterns by checking a data point's neighbors. If a patient's data looks similar to other patients who historically had poor outcomes, the model predicts they might too. KNN has achieved accuracies of 98.38% in some studies.
Wow, over 98% accuracy.
Yeah, and other models like Random Forest and XGBoost also perform very well, around 95% accuracy. KNN also boasts an impressive AUC of 0.98 in some datasets, indicating its remarkable ability to differentiate between high-risk and low-risk individuals for diabetes complications.
What kind of data do they use for that?
They analyze a broad range of features, often from large public health datasets like the Behavioral Risk Factor Surveillance System, BRFSS. Things like demographics, BMI, blood pressure readings, cholesterol levels, even education level and lifestyle factors to predict the presence of diabetes or prediabetes or risk of complications.
And you mentioned balancing data.
Right. Techniques like SMOTE, or sometimes SMOTE-N, are frequently used here. If, say, severe complications are rare in the dataset, SMOTE helps by digitally creating more synthetic examples of those rare cases. This helps the AI learn from a more balanced dataset and make more reliable predictions, especially for conditions or outcomes that don't occur frequently in the historical data. It prevents the model from just ignoring the rare but important cases.
That makes sense. Finally, for workflow facilitation, specifically that automated medical coding, what kind of performance are we seeing with natural language processing and those newer large language models?
This is an area of truly significant and very rapid advancement, primarily driven by exactly those technologies: natural language processing, deep learning, and large language models.
LLMs.
And the accuracy. Automated medical coding for complex classifications like ICD-10, CPT, HCPCS, and E&M codes derived directly from unstructured clinical notes or even those transcribed physician-patient conversations we discussed. It reports astonishing accuracy rates, consistently ranging from 95% to over 98%.
95 to 98% plus, just from reading notes or listening in.
Essentially, yes. The AI learns the patterns linking clinical language to specific codes, and the outcomes are directly tied to revenue cycle efficiency and compliance. These systems lead to reduced claim denials by up to 70%, significantly reduced chart review time by human coders, sometimes by 60% to 80%.
Freeing them up for complex cases.
Exactly. And an impressive increase in charge capture, making sure all billable services are actually coded by up to 15% in some cases. This clearly illustrates the immense value of advanced NLP in streamlining these previously burdensome administrative tasks and ensuring accurate financial operations.
Okay, so the performance metrics look really strong across the board, especially when you factor in the real-world outcomes.
They really do. And if we connect these technical findings to the bigger picture, they reveal some crucial and overarching trends across all these diverse AI applications in ambulatory care.
What are those key trends?
Well, first, for tasks involving highly structured data, think tables of numbers, patient histories, appointment times, like in predicting no-shows or hospital readmissions. Ensemble methods consistently outperform simpler models.
Ensemble methods, like random forest.
Exactly. Random forest and gradient boosting are prime examples. Think of ensemble methods like having a committee of highly intelligent experts. Each expert analyzes the data slightly differently, maybe focusing on different features, and then they combine their individual votes or predictions to arrive at a much more robust and accurate collective decision.
The wisdom of the AI crowd.
Kind of, yeah. They achieve AUCs well above 0.90 in many cases, indicating their exceptional capability to capture the complex, nonlinear relationships within the data. Things aren't always simple cause and effect. Factors interact in subtle ways, and these models are great at uncovering those hidden connections.
Okay, so ensemble methods for structured data. What else?
Second, for workflow facilitation tasks, particularly that automated documentation and coding natural language processing, is the absolute core technology. It's all about understanding language. Modern systems are increasingly leveraging those large language models, the LLMs.
The tech behind things like ChatGPT.
Was the same fundamental type of AI? Yes, but specifically trained on medical language and concepts. They use that, along with deep learning algorithms, to gain unparalleled power in interpreting the nuances of unstructured clinical notes and spoken conversations. This allows them to achieve that very high accuracy in suggesting codes and generating documentation. And critically, these tools are designed to integrate directly into EHRs, providing real-time support right where clinicians need it.
Making it seamless.
Exactly. And third, a foundational principle that absolutely underpins all of this impressive performance. It's the paramount importance of data quality and effective feature selection.
Garbage in, garbage out, right?
Precisely. The performance of any machine learning model is inherently limited by the quality and relevance of the data it's fed. For example, in no-show prediction, features like appointment lead time and prior no-show history are incredibly powerful predictors the AI learns from past behavior. For readmission risk, the number of prior hospitalizations is a critical piece of information flagging vulnerability.
So choosing the right data is key.
Absolutely. And preparing it properly. It's also essential to address data imbalance, like we discussed with Z-Mode, to build robust models, especially when dealing with rare events or predicting behaviors that don't happen often. Without high-quality, relevant data, meticulously prepared and presented, even the most advanced algorithms simply won't yield optimal results. Data is the fuel.
So what does this all mean when it comes to actually getting these powerful AI tools out of the lab, out of these studies, and into real clinics? Having doctors, nurses, staff actually use them every single day. This sounds like a truly massive undertaking, far beyond just plugging in some new software.
You've hit on the absolute core challenge, and honestly, the most critical insight from the source material we're looking at. The guiding principle for successful AI implementation is crystal clear. It is fundamentally a change management challenge, much more than it is a technology rollout challenge.
Change management, meaning the people side of things.
Exactly. The most sophisticated algorithm, even with those impressive performance metrics we just discussed, will utterly fail if it isn't embraced, trusted, and adopted by the frontline staff, the physicians, the nurses, the medical assistants, the administrators who have to interact with it every single day.
So the barriers aren't usually technical.
Rarely the main ones. The primary barriers to AI success are overwhelmingly human and organizational. We're talking about understandable factors, right? Like a lack of trust in this new black box technology, the real or perceived potential for workflow disruption. Is this going to make my job harder? And often, just insufficient training or ongoing support.
People need to feel comfortable and confident.
Precisely. So a truly successful implementation strategy must prioritize the people side of this change. It has to actively bring staff along on the journey, address their concerns head-on, build trust, and clearly demonstrate the tangible benefits to their daily work, not just to the organization's bottom line.
That makes so much sense. It's about empowering people, not just deploying code. So where do organizations even begin? If they want to start this journey, what's the first phase? How do you lay this crucial groundwork for such a significant transformation?
Right, you need a solid plan. The first phase, which the source calls the foundation, typically spans the first 1 to 3 months and is entirely focused on strategic planning and rigorous assessment, getting your ducks in a row.
Okay, months 1 to 3. What's step 1?
Step 1 is usually forming a cross-functional AI steering committee. This isn't just an IT project. It needs dedicated, collaborative leadership.
Oh, should be on it.
It absolutely must include an executive sponsor, someone high up to ensure organizational support and resources, a clinical champion, a respected doctor or nurse who can advocate for the medical staff and ensure clinical relevance, an operational lead, maybe a practice manager to handle the day-to-day practicalities, an IT lead, of course, for technical integration, and, crucially, representatives from the frontline staff themselves, nurses, MAs, maybe even front desk staff.
Getting buy-in from all levels right from the start.
Essential. This diverse representation ensures all perspectives are at the table from day one, fostering that sense of shared ownership.
Okay, committee formed. What's next in the foundation phase?
Next comes the strategic assessment and use case selection. You don't just, throw AI at every problem hoping something sticks. You have to be strategic.
How do you choose where to start?
You begin by meticulously auditing your existing systems. Sometimes there are AI capabilities already in your EHR that aren't being used. And critically, you identify the most pressing pain points your clinic faces related to patient flow, patient labeling, and workflow. Where are the biggest frustrations? Where are the bottlenecks?
And then match AI to those problems.
Exactly. The source introduces a helpful conceptual framework, they call it the 3 Rs, to guide this selection. Repetition. Like highly repetitive, time-consuming tasks like documentation or medical coding. AI is great at automating those.
R number 1, repetition.
Recognition. Like pattern recognition, identifying high-risk patients from complex data who might otherwise be missed.
R number 2, recognition.
And reasoning, things like predictive analytics, predicting patient no-shows, or optimizing complex schedules based on multiple factors.
R number 3, reasoning. Repetition, recognition, reasoning. Nice framework.
It helps categorize the problems AI is well suited to solve. And a key piece of advice here, really critical for success, prioritize a pilot project that addresses a major, universally felt frustration among staff, like that burden of documentation we keep talking about.
Why start there?
Because it's vital for building crucial buy-in. If your first AI project demonstrates immediate, tangible value that directly improves the daily lives of your clinicians, they become champions. It builds momentum and trust for future, maybe more complex initiatives. Start with a win.
That's incredibly smart. Start with something that genuinely makes their lives easier to get them on board. And measuring success is absolutely key too, right? You said you need empirical evidence. You can't improve what you don't measure.
Absolutely indispensable.
Hmm.
Before you implement anything at scale, you must meticulously define success by establishing baseline key performance indicators, or KPIs. You need to rigorously measure the current state before implementation. How long do patients wait now? What is our no-show rate? How much time are clinicians spending on notes?
Get that baseline measurement.
Right, so you have an objective benchmark against which to track improvements later. Essential KPIs for these kinds of AI applications typically include patient no-show rate, average patient wait times, clinician documentation time, maybe measured by EHR logs or surveys, coding accuracy rates, claim denial rates, and crucially, don't forget staff satisfaction scores. Ask them how they feel.
Get both the hard numbers and the human feedback.
Exactly. These metrics provide objective, quantifiable evidence of the AI's actual impact. And finally, in this foundational phase, there's often a critical build versus buy decision.
Build your own AI or buy a solution.
Yeah. For common, well-defined problems like scheduling optimization or automated coding, there are often excellent commercial solutions available from established EHR vendors or specialized third-party AI companies. These are often faster to implement, more robust because they've been tested elsewhere, and significantly more cost-effective, especially for smaller practices.
So buying is often better.
Often, yes. Building a custom AI model from scratch, while sometimes necessary for very unique niche institutional needs, is a massive undertaking. It requires significant in-house data science expertise, lots of data, and dedicated resources. It's usually best suited for very large health systems with specific, complex challenges not addressed by off-the-shelf products.
Good practical advice. Okay, so once that solid foundation is laid, committee formed, use case chosen, KPIs defined, build versus buy, decided, what does the action phase look like? How do you actually get this powerful technology into people's hands and start seeing those results you measured?
Right, now we move into phase 2, action. This typically spans months 4 to 9 and focuses on a controlled strategic deployment and refinement. A truly crucial element here, building on the foundation, is to engage the full care team deeply.
More than just informing them.
Much more. It means actively involving the end users, the physicians, the nurses, the MAs, who will actually use the tool in the design and testing process itself.
How do you do that effectively?
This could be done through things like dedicated co-design workshops, usability testing sessions, feedback forums. Their insights are invaluable for shaping the tool, ensuring it's intuitive, user-friendly, and genuinely solves their actual problems, rather than creating new workflow headaches.
Making sure it works for them, not against them.
Exactly. And building trust is paramount throughout this phase. That means absolute transparency about how the AI model works, at least conceptually, what data it uses, what its known limitations are, and constantly reinforcing how it will support their vital roles, not replace them, addressing those fears directly.
Okay, deep engagement and trust building. Then how do you actually roll it out all at once?
Definitely not. The recommendation is strongly for a phased implementation approach, a big bang rollout where you try to implement everything everywhere all at once across the entire organization is inherently risky and often leads to chaos and failure. So start small. Yes. Adopt a crawl, walk, run mentality. Start with a single department, or maybe a small group of change champions. Those early adopters who are naturally enthusiastic about new technology and willing to experiment and provide honest feedback.
The pioneers.
Exactly. This allows the organization to test the technology and the redesigned workflow in a controlled environment. You learn from any initial glitches or challenges. You adapt the tool or the process quickly before attempting a wider rollout. It de-risks the whole process.
Makes sense. And training must be huge here, too.
Absolutely critical. You must develop robust, role-based training. Training cannot be a superficial, one-off, check-the-box event. It needs to be ongoing, hands-on, and meticulously tailored to each specific role and their unique workflows. A doctor using an AI scribe needs different training than an MA using a new scheduling tool.
Tailored training. What should it cover?
It should focus not just on the how, click here, do this, but critically, the why behind the change. How does this help the patient? How does it make your job easier or better? And provide ample hands-on practice in a safe, non-production environment so people can get comfortable without fear of messing up real patient data.
Practice makes perfect.
And encourage sharing success stories. When those early adopters start seeing benefits, less documentation time, smoother schedules, having them share those stories with their peers is incredibly motivating, creates organic champions within the organization.
So it's about making sure everyone feels supported, understands the tangible benefits to them personally, and feels a sense of ownership over these new tools. And then how do you ensure continuous improvement once it's in use and maybe starting to grow beyond the pilot?
That leads directly to the final crucial point in this action phase. Establish strong feedback loops. You need simple, clear, and easily accessible channels for users to provide feedback, whether it's reporting a bug, suggesting an enhancement, asking a question, or even sharing a positive experience.
Make it easy for them to speak up.
Exactly. And critically, leadership and the implementation team must actively listen to this feedback. They need to demonstrate that user input is valued, that it's being heard, and that it leads to tangible improvements or responses. Acting on feedback builds that crucial sense of ownership among the staff. It ensures the AI tool continuously evolves to meet their real-world needs rather than becoming static and outdated.
So it's a continuous dialogue.
Absolutely. It transforms the AI from just a static tool that was deployed into a dynamic partner in care that gets better over time because the users are helping to shape it.
All right, so we've planned meticulously in the foundation phase, we've executed successful pilots and engaged users in the action phase, and we've hopefully garnered some early wins and positive feedback. Now what? How do you strategically scale this beyond a single department or a group of champions and truly embed AI into the fabric of the organizational culture for the long term?
This brings us to phase 3, scale. This typically begins around month 10 or so, once the pilot has proven its value, and it really extends indefinitely, because AI isn't a one-time project. With a successful pilot providing clear, objective evidence of value, the focus shifts to broader deployment and consciously cultivating what the report calls an AI-ready culture.
AI-ready culture sounds important. What's the first step in scaling?
The first crucial step is to monitor and evaluate against KPIs continuously. You don't stop tracking just because the pilot is over. You must keep tracking those key performance indicators that were established way back in phase 1 wait times, no-show rates, documentation time, staff satisfaction without interruption as you roll it out more broadly.
Why keep tracking so closely?
It provides objective, ongoing evidence of the value AI is bringing across different areas. It helps identify departments or workflows where it's working exceptionally well, and maybe areas where further optimization or support is needed. And it informs strategic decisions on where and how to scale next. This isn't a one-time check. It's a persistent analytical oversight function. Data-driven scaling.
Okay, continuous monitoring. Then you mentioned something about permanent governance.
Yes, this naturally raises a really important question the source addresses. Why establish permanent AI governance? Why permanent?
Yeah, why? Once it's working, isn't it just working?
Not necessarily. It's permanent because machine learning models are not static entities. They can drift over time.
Drift. What does that mean?
It means their performance can degrade gradually. As clinical practices evolve, as patient populations shift, as new medications or treatments emerge, or even as the way data is entered into the EHR changes slightly, the model's accuracy might slowly decrease because the world it was trained on is no longer exactly the world it's operating in.
Ah, so it needs maintenance like any complex system.
Exactly. A permanent, ongoing governance structure, likely involving members from that initial steering committee plus others, is absolutely essential to manage the entire life cycle of the AI models in production.
What's their responsibility?
This body is responsible for things like regular revalidation of the model's accuracy against current data, conducting periodic audits to ensure fairness and check for bias, making sure the AI isn't disadvantaging certain patient groups, and ensuring continuous compliance with all relevant ethical guidelines and evolving regulatory standards, like HIPAA and beyond. It's a critical oversight function for responsible, effective, and equitable sustained use of AI.
So it's not just about building it and forgetting it. It's about constant monitoring, adaptation, and accountability. Got it. And then how do you strategically expand these successes across the entire organization? Do you just flip a switch?
Definitely not flipping a switch.
Yeah.
You scale success strategically, you leverage the invaluable lessons learned, both good and bad, from the pilot phase, and crucially, you empower those change champions from the pilot.
Use the early adopters?
Absolutely. They become powerful internal advocates. They can share their positive experiences firsthand with their colleagues. They can help train others. They can ease anxieties. They help drive wider adoption organically across the organization, peer-to-peer. And finally, alongside scaling specific tools, you must actively foster continuous improvement as an organizational value.
Making innovation part of the culture.
Precisely. AI isn't a one-time project that ends when a system goes live. That cross-functional steering committee, or the governance body, should remain actively engaged. They should be continually scanning the horizon for new, high-value use cases for AI as the technology evolves, and fostering a culture where staff feel empowered to suggest ideas for improvement or new applications. This ensures that the healthcare system remains agile, responsive, and continuously finds new, better ways to leverage AI for improved patient care and operational efficiency. It's about embedding that proactive, adaptive mindset into the organizational DNA.
Here's where it gets really interesting, I think, for a lot of people listening. If AI is taking on all these tasks we've discussed, optimizing schedules, predicting risks, handling documentation, doing initial coding, maybe even assisting with triage. What does this mean for the healthcare professionals themselves? The doctors, the nurses, the MAs? Are their jobs changing fundamentally? Or are they even disappearing? This must be a huge concern for the people on the front lines, right? That fear of replacement.
This is perhaps the most crucial and often the most misunderstood aspect of AI integration in healthcare. And yes, that fear is real and needs to be addressed directly. The core idea, which the report emphasizes with great clarity and which I think is vital to grasp, is that the integration of AI is not about replacing healthcare professionals.
Okay, that's important. Not replacement, but
Instead, it is about profoundly augmenting their capabilities and strategically reshaping their roles. Think of it as partnership, not substitution.
augmenting and reshaping. How so?
Well, AI excels at certain things. Rapid data processing, identifying complex patterns in vast data sets that humans might miss, and automating highly repetitive, routine tasks that often don't require complex judgment.
The things that machines are good at.
Exactly. Humans, on the other hand, excel at things like empathy, nuanced communication, complex ethical judgment, creative problem solving, and truly understanding individual patient needs and contexts in a holistic way. The things that require human connection and wisdom.
So it's about combining strengths.
Precisely. The goal is to forge a synergistic partnership, allowing human staff to offload the repetitive, lower value, often burdensome tasks to the AI. This frees up their invaluable expertise, their compassion, their critical thinking skills, and their energy to focus on higher value activities that uniquely require human skills and interaction.
Okay, let's break that down role by role, starting with the physician. If AI scribes are handling documentation, maybe AI is helping with initial diagnoses or risk scores. What does that mean for their day-to-day role? How does their job fundamentally get reshaped?
For the physician, AI promises extraordinary relief by significantly offloading those crushing administrative burdens we talk so much about. As we discussed, ambient AI scribes and sophisticated NLP tools can automate clinical notes, reducing that documentation time by 50% or even more.
freeing up half their admin time.
Exactly. And crucially, this directly translates into cutting reported feelings of burnout by as much as 70% in some studies using these tools. This is genuinely transformative for their work experience. It fundamentally frees physicians from being, as the report rather aptly puts it, data entry clerks.
So what do they become instead?
They are empowered to become high-level clinical strategists. They will interpret the AI-driven insights like that complex patient risk score or the triage suggestion or maybe differential diagnoses offered by an AI, and then they integrate these sophisticated data points with their own extensive clinical experience, their deep medical knowledge, their intuition built over years, and their understanding of the individual patient sitting in front of them.
So AI provides the data, the doctor provides the wisdom and context.
Perfectly said. Their role shifts to one of elevated cognitive engagement. More time spent on complex problem solving, on nuanced decision making, on building rapport, and on having those crucial, unhurried conversations with patients. They focus on the judgments and critical decisions that only a human physician with their training and empathy can truly make. Imagine a doctor leaving the clinic not drained by paperwork, but actually energized by the intellectual challenge and the human connections they made.
That sounds like a powerful, incredibly positive shift, giving doctors more time to actually be doctors and less time being glorified typists or data processors. What about nurses? Their role is absolutely critical, very hands-on. How does their job evolve with AI as a partner?
The nurse's role will also be significantly augmented and, frankly, elevated by AI integration. AI will automate much of the routine monitoring, perhaps analyzing streams of data from wearables or bedside monitors, repetitive data collection, and basic documentation tasks that currently consume a large portion of their valuable time.
Taking away some of the routine charting and checks?
Exactly. This strategic automation elevates the nurse's role, allowing them to focus more intensely on what they do best. Complex care coordination across different providers and settings, in-depth patient education tailored to individual learning styles and needs, and providing that essential, compassionate, hands-on, direct care and advocacy.
Can you give an example?
Sure. Think back to that scenario where an algorithm flags a patient as high risk for hospital readmission upon discharge. The AI identifies the risk, but it's the nurse who then performs the intricate, human-centric coordination needed to actually prevent that readmission.
The human follow-through.
Right. The nurse provides tailored education to the patient and their family on discharge instructions, warning signs, medication management. They might arrange necessary follow-up services like home health visits or physical therapy. They communicate effectively with the patient's primary care doctor and any specialists involved. They address social determinants of health that might be barriers. It's that complex, empathetic coordination that truly mitigates the risk.
So the AI flags it, the nurse acts on it with skill and compassion.
Precisely. Nurses will increasingly become the primary human interface for many of these new technologies in the clinical setting. This will require them to develop new proficiencies in effectively utilizing these AI tools, validating their outputs, not just blindly trusting them, and critically appraising the information AI provides to enhance, not replace, their own clinical judgment and vital care delivery.
And medical assistants, the MAs. They're often the first point of contact, handling so much administrative support and basic clinical tasks. How does AI transform their everyday responsibilities? Their role seems ripe for change.
The medical assistant's role is indeed poised for a truly significant transformation, perhaps one of the biggest shifts. It moves from primarily administrative support and task execution towards a more dynamic, patient-facing, and tech-enabled role.
How so? What tasks does AI take over?
As AI intelligently automates many core administrative tasks, things like initial patient scheduling based on rules and predictions, sending out routine appointment confirmations and reminders, handling basic patient messages or requests through portals, the MA's value shifts profoundly.
Shifts towards.
Towards higher-level patient navigation and, very importantly, adeptly managing the clinic's increasingly tech-enabled workflows. They won't just be checking people in, taking basic vitals, and rooming patients, although those tasks may remain.
What new responsibilities might they take on?
They will likely become key players in managing exceptions within those AI-optimized schedules, handling the tricky cases the algorithm can't solve. They might proactively troubleshoot patient technology issues to facilitate smooth telehealth visits. Critically, they could take on a larger role in educating patients on how to effectively use the various digital health tools the clinic offers, patient portals, remote monitoring devices, AI-powered symptom checkers.
Becoming tech guides for patients.
Exactly. They will become the essential human guide, the trusted navigator for the patient's entire journey through this augmented clinic. ensuring a smooth, technology-supported, but still personalized and reassuring experience. They bridge the gap between the tech and the patient.
Finally, what about the people running the show? Clinic administrators, practice managers. For them, it must be less about direct patient care changes and more about overall operational strategy and efficiency, right? How does AI change their jobs?
You're right, for clinic leadership administrators, practice managers, AI provides the powerful tools to fundamentally move away from a reactive, day-to-day firefighting mode.
Dealing with constant crises.
Exactly. And move towards truly proactive, data-driven operation strategy and management.
How does AI enable that shift?
Those AI-powered analytics dashboards we talked about offer real-time, comprehensive insights into patient flow dynamics. Where are the bottlenecks right now? Resource utilization across the clinic, are exam rooms sitting empty while patients wait? And nuanced revenue cycle performance, where are claims getting denied and why?
Giving them real-time visibility.
Visibility they likely never had before, or only got weeks later in reports. Instead of manually creating complex staffing schedules based on historical averages or just guesswork, or trying to retrospectively figure out why revenue targets aren't being met, managers can leverage predictive analytics. They can forecast patient demand with much greater accuracy, optimize staffing levels and resource allocation weeks or months in advance.
Moving from reaction to prediction and planning.
Precisely. This allows them to dedicate more of their valuable time and expertise to longer-term strategic planning, leading continuous quality improvement initiatives, fostering a positive and efficient clinic culture, and addressing systemic issues rather than constantly reacting to immediate operational fires. AI gives them the tools to manage smarter, not just harder.
So what does this all mean? If we try to connect all these threads, the patient flow optimization, the intelligent labeling, the workflow facilitation, the performance data, the change management, the shifting roles, if we connect this to the bigger picture, it's clear AI isn't just about incremental efficiency gains, is it? It seems like it's about fundamentally reshaping the very landscape of ambulatory healthcare.
That's exactly right. It's an exciting, definitely complex, but ultimately a deeply human-centered transformation if it's done thoughtfully.
It seems the intelligent integration of machine learning into ambulatory care isn't just like a nice-to-have option for healthcare organizations anymore.
No, it's rapidly becoming a strategic imperative, essential for improving both operational efficiency and, more importantly, the quality, accessibility, and experience of patient care. The robust evidence we've explored today clearly indicates that AI can deliver truly substantial, measurable value in those core operational areas: patient flow, intelligent patient labeling, and workflow facilitation.
So, for healthcare leaders listening, maybe contemplating this transformation, what are the key takeaways, the concluding recommendations based on this analysis?
Yeah, based on the source, a few key recommendations really stand out as paramount for navigating this successfully.
Okay, let's hear them.
First, prioritize workflow and flow. Initial AI investment should strategically target those operational areas that offer clear, measurable return on investment and, critically, have a direct, positive impact on staff workload and well-being.
Start where the pain is most felt.
Exactly. Applications like intelligent no-show prediction or automated clinical documentation are often excellent quick wins. They directly address immediate, widely felt frustrations among clinicians and staff. These foundational successes are absolutely vital for building that crucial buy-in and momentum you need for maybe more complex, broader clinical AI initiatives down the road. Start practical, show value quickly.
Okay, prioritize workflow and flow, get quick wins. What's second?
Second, always focus on augmentation, not replacement. This is so critical for fostering trust and ensuring successful adoption. The narrative surrounding AI, both internally and externally, must always be one of partnership and empowerment.
How you frame it matters.
Hugely. AI should be meticulously framed, designed, and strategically deployed as a powerful co-pilot, a tool that augments the existing skills of clinicians and staff. It frees them from the routine administrative tasks, allowing them to dedicate their unique human focus to complex decision-making, critical thinking, and building and nurturing those essential human-centered patient relationships. This augmentation framing is absolutely fundamental to gaining the trust needed for successful organization-wide adoption. People need to see it as helping them, not replacing them.
Augmentation over replacement. Got it.
Third, treat AI as a change management initiative first and foremost. As we've emphasized throughout this discussion, the ultimate success of any AI project is often more dependent on the human factors, how people perceive it, adopt it, adapt to it, than on the technical brilliance of the underlying algorithm itself.
The people piece is paramount.
Absolutely. This means allocating significant dedicated resources, time, budget, personnel specifically to change management. This includes that early and continuous stakeholder engagement at all levels, comprehensive and truly role-based training tailored to specific needs and workflows, and clear, consistent communication about the why behind the change. Explaining the tangible benefits to staff and to patients is key. People need to understand how it makes their work better and how it improves patient care.
Invest heavily in the people side. Makes sense. What's number 4?
Fourth, establish permanent AI governance. Remember, AI is not a static technology you just install and forget. It's dynamic. It evolves. Models can drift. Regulations change. Ethical considerations emerge. Therefore, healthcare organizations must establish a permanent, cross-functional governance committee.
To oversee things long term.
Exactly. To oversee the entire life cycle of their AI models in production. This body needs to be responsible for ongoing monitoring of model performance, conducting those periodic audits for fairness and bias to ensure equitable care delivery, managing model updates and retraining, and ensuring continuous compliance with all relevant ethical standards and regulatory requirements. It's about ensuring responsible, effective, and sustained use of AI over the long haul. It's not optional for responsible AI use.
Permanent governance for long-term health. Okay, and the final recommendation?
And finally, number 5, rethink and retool the workforce proactively. Don't wait until roles have already been disrupted. Proactive planning is absolutely required for the inevitable evolution of both clinical and administrative roles within the ambulatory clinic of the future.
Preparing people for the change.
Yes. The future ambulatory care team will increasingly function as a sophisticated human-AI collaborative. This necessitates investing now in comprehensive training and development programs. Programs that equip staff with new, essential skills, things like basic data literacy, the ability to critically appraise AI outputs and insights, not just blindly accept them, and proficiency in technology-facilitated patient communication and virtual care tools. It's about empowering the existing workforce, preparing them with the tools, skills, and knowledge they need to thrive, not just survive, in tomorrow's augmented healthcare environment.
So prioritize workflow, focus on augmentation, treat it as change management, establish permanent governance, and proactively retool the workforce. That's a solid roadmap.
It provides a strong framework for approaching this complex but potentially transformative journey.
Okay, so as we wrap up this deep dive, here's a final thought for you, our listener, to maybe mull over. As AI increasingly takes on the heavy lifting, the data processing, the pattern recognition, the routine administrative tasks in clinics and doctors' offices, what new frontiers does this open up? What becomes possible for human creativity, for genuine empathy, for real connection in the healthcare experience?
That's a powerful question.
How might this profound shift in focus away from tedious data entry and towards high-level clinical strategy, complex problem-solving, and deeply compassionate human-centered care? How might that impact the very joy and satisfaction of working in healthcare? And perhaps most importantly, how might it ultimately elevate the quality, the humanity, and the effectiveness of the care you receive next time you visit your doctor?